Hi everyone, my name is Francesco Maisano. We are at PCR London Valves 2025 and I have the pleasure and honor to be together with Michael Borger, the co-chair of the latest valvular heart disease guidelines. And I'm very happy to entertain with you some questions regarding the impact of the guidelines in real practice, in our practice as physicians, in the field of mitral. And obviously we should starting from primary and going into secondary MR. So, Michael, what is changing in the field of primary?
Yeah, so we had a large task force of surgeons, cardiologists, and I had, of course, the honor of co-chairing the ESC, EACTS 2025 valvular heart disease guidelines together with Fabian Prats. And in primary MR, we have some new recommendations and some revised recommendations that are very important. We're seeing in our practice, and as a surgeon, this is something that's been going on for years, that we're seeing more and more asymptomatic patients being referred earlier in their disease process. And this is something that we also tried to stress in this newest version of the guidelines, is that we want the referring physicians to start thinking about intervention at least earlier in the disease process before it's too late. So for primary MR, surgery still remains the procedure of choice for low-risk patients if they have symptoms, or if they're asymptomatic with LV dysfunction. That hasn't changed, but we have a new 1B recommendation for patients that have 3 or 4 of the risk factors: atrial fibrillation, pulmonary hypertension, LA dilatation, or secondary TR. So this is a new recommendation.
So basically intervene timely. That is probably the most important factor. And somehow, does it also reflect the tendency into secondary MR? So what's going on? That is probably the major change that we have seen.
So first of all, we clearly defined then the two separate, very different patient groups: atrial secondary MR from ventricular secondary MR. And it's also important to note that if you wait too long for atrial secondary MR patients, they will transition into a combined pathology, and then it's too late. So once again, reiterating the fact that we want to intervene earlier in the disease process for these patients with atrial SMR. And as you know, we have a new 2A recommendation for surgical treatment of atrial secondary MR when the patients are symptomatic, and we have a new 2B for transcatheter therapy, so TEER, for those same patients. Within ventricular secondary MR, we now have a new Class 1 recommendation for TEER for symptomatic patients based on the results of 3 randomized trials and a meta-analysis showing that these patients have less rehospitalization for heart failure and better symptom control with TEER therapy.
So that is obviously very well accepted, and everybody who has been involved in transcatheter interventions in heart failure is very happy. Obviously, there is still need for educate the community and implement these guidelines into practice. So let me ask you a personal question now to you. How your practice will change, or are you already somehow acting according to current guidelines?
I think we have more asymptomatic patients that are coming with primary MR, so that is a change that we've noted. We also have already for a couple of years gotten rid of the preoperative invasive angiography for patients that are at low or moderate risk pre-test probability for coronary artery disease, and that's a new Class 1 recommendation as well. I'm sure you're experiencing the same change in your practice in San Rafael. And I think this is just a recurring theme that we're going to see more and more asymptomatic patients, at least for the primary MR in the future. And we also have new definitions for intervention based on volume indices, so also taking into account the size of the patient, because if you wait until you reach those traditional cutoffs, sometimes it's too late.
So Michael, let me summarize. First of all, I want to really thank you, the co-chair Fabian is another friend, and the group of experts who have been suffering for maybe more than 1 year to try to implement guidelines to direct the community. And I think what is important for us in daily practice is that now we have more evidence supporting some of our established practices. But what is important, in my opinion, is that the guidelines underline once more the importance of heart team approach to valve disease, the importance of multi-professionality around the patients, intervene timely, which means we need to invest time into education and awareness campaign. And using the latest guidelines, I think we are going to be able to treat our patients better in a timely fashion using all the armamentarium which is available.
Maybe if I can just make one more point, when you say patients, treating our patients better, it's also important to point out we had 2 patient representatives, one from ESC and one from EACTS, and they were adamant in saying that we need to stress the outcome volume relationship, and that patients with complex disease or those patients requiring complex procedures go to the high volume centers, and the patients are demanding this. So I think this is something that we should also respect.
Excellent. Thank you very much, Michael, and stay tuned for more on PCR Online.